Hello guys, thank you for being here in this channel. Don't forget to subscribe and hit the like button. Um, um, just remember this is Usmle step 2 CK. Today is November 30, 2022. So this is good when you're driving or doing something. You can hear my voice to review some content. In the meantime, you're doing your stuff, you're driving, or you're doing homework at home, and you do any kind of, if you cannot have a book in front of you or a computer, you can hear my voice, and then you can do some kind of review with this. So again, thank you for being here. Don't forget to hit the like button and subscribe. Let's start reading. So what I'm gonna do, I'm gonna be reviewing some questions, and I could be reading on. I have some PDF materials so I can find out instead what other subject and so other subject into another like material. So let's see. So I have been reading a question here that is about a 2 years old girl. She was brought to the office for a routine child evaluation. The father stated that the patient has been healthy and can run and climb stairs, eat with a spoon. He is 2 years old girl, so she will 4 blocks tower. So it's good. Everything looked good there. The patients recently start saying couple words. Father says she had a lot of difficulties adjusting to a new routine, a daycare, and her teachers commented that she insists in playing with the same toy. So that's important. She insists on play with the same toy train for hours, and mostly keep it to itself. So her sister was also shy and late to talk, and is doing great now. So I think it just run in the family. So the weight and height and head circumference at the age are tracking consistently at the 60%. So the weight and height and head circumference are okay. On physical examination, the patient does not look up. The patient does not look up when her name is called. The patient does not look up when their name is called. The remainder of the physical examination is normal. The physical examination is normal. So a hearing test is performing and is normal too. Okay. So the most important you can take here is the little kid just want to play with the same toy for hours. This is important. So a hearing test was normal. So which of the following is the most appropriate treatment? So which of the following is the most appropriate statement? I'm sorry, statement, not treatment, statement. So obviously you guys have in your mind what you think it is. So let's see the options. So it's a little kid that always like to play with the same toy for hours, and when you call her name, she doesn't answer. The kid is in her own world. So let's see. Though it's normal for children to reach milestone at different times, I'm concerned that some of the difficulties may be due to anxiety. I don't think that 2 years old boy anxiety. I don't know. Her recent advancement and language is reassuring. Let's monitor her development closely for the next 3 months. Refer to a specialist if it is necessary. That's some kind of, let's say, some children are shy and some quite temperament. I recommend that she engage in play therapy to develop her social skill. Speech delay can follow similar patterns in siblings since her milestones are otherwise normal. We can keep monitoring her at regular follow-up visits. And the last option is you are correct. That milestone can vary between children. Okay, however, I recommend doing a more detailed assessment to evaluate all aspects of the development. So this is the correct answer. This is a little boy with a spectrum disorder, autism spectrum disorder. So when they give you the vignette and they say they she insists on playing with the same toys for hours and mostly keep it by itself and doesn't want to play with anybody else. So this is important to think it could be autism spectrum disorder. Autism spectrum disorder. So the correct statement for the doctors could be you are correct that milestone can vary between children. However, I recommend doing a more detailed assessment to evaluate all aspects of her development. Okay, that's the correct answer. Sorry, I don't show you the images because I don't want to get any copy strike or some things like that, so I cannot be showing the questions on the screen. So this is good for you can hear my voice, and remember you can hear my voice and do some review. This is supposed to, you have supposed to have been reading those questions before, so this is important to review. Okay, let's keep going. So he said autism spectrum disorder. So the clinical features of autism spectrum disorder. So let me get you guys something so you can autism spectrum disorder. You can hear that.
A 2-year-old girl is brought to the office for a routine child evaluation. On physical examination, the patient does not look up when her name is called. The remainder of the physical exam clinical features. 1. Impaired. 1. Deficits in social communication and interactions with outset in early childhood. 1. Impaired social engagement, e.g., back and forth conversation. 2. Impaired nonverbal communication, e.g., eye contact, gesturing. 3. Difficulty developing, understanding relationships, e.g., interest in peers. 2. Restricted, repetitive patterns of behavior. 1. Repetitive movements or speech. 2. Insistence on sameness, routines. 3. Intense fixated interests. 4. Adverse responses to sensory input, e.g., textures. 3. May occur with or without language and intellectual impairment. Assessment and management principles. 1. Early diagnosis and intervention. 2. Comprehensive multimodal treatment, e.g., speech and behavioral therapy, educational services. 3. Adjunctive pharmacotherapy for psychiatric comorbidities. At age 2, children typically say many words, usually 20 plus, and use 2-word phrases. This patient who only recently started saying a couple of words has language delay. Although language delay is often an isolated finding, this patient also has behavioral features concerning for autism spectrum disorder, ASD. ASD is characterized by poor social communication skills, e.g., lack of response to name, poor eye contact, and restricted, repetitive behaviors, interests, e.g., fixed interest in one toy, difficulty adapting to new situations, as seen in this patient. Most 2-year-old children do not yet engage in interactive play, but parallel play, i.e., playing adjacent to others, is expected and not noted in this patient's history. Language deficits, e.g., speech delay, echolalia, are also common in ASD. Diagnosis requires a standardized, detailed assessment of social and developmental skills, typically performed by a developmental pediatrician or child neurologist, in which a child's behavior is observed while performing a variety of activities. In a child with suspected autism, early intervention, in the form of educational and behavioral services, e.g., speech therapy, applied behavioral analysis, can significantly improve outcomes and may be initiated while...
Okay, sorry about that. I was trying to find for you some. Let me read it for you, okay? So autism spectrum disorder, clinical features, difficult in social communication and interactions with onset of early childhood. So the kids have difficult in social communication and interactions with other kids. You have impaired social engagement, so doesn't like to stay playing with other kids. You can like interact for a little bit, and then you cannot stay engaged with playing with some kids. By example, back and forth conversation. So impaired social engagement, impaired non-verbal communication, by example, eye contact, history. So difficult to develop an understanding of relationships. By example, interest in peers, interest in friends, and things like that. So restricted, repetitive pattern of behavior, restricted or and repetitive pattern of behaviors. So repetitive movement or speech, insistence and insistence in sameness routines. So if you when they get out of the routine, they get mad or things like that. When they get out of their routine. Intense fixed interest in intense fixed interest. So all of this is part of the autism spectrum disorder clinical features. So advanced response to sensory input, textures, like they touch something and they react when they touch some kind of texture or something. They have advanced response to sensory input, so they don't want to be touched probably or bother for anybody they don't know, or may occur with or without language or intellectual impairment. There's intense fixed interest, intense and sameness routines. They like the same routines all the time. Repetitive movement or speech, restrictive repetitive pattern of behavior, difficult social communication and interaction with early childhood, impaired social and engagement, impaired nonverbal communication, difficult to develop and understanding relationships. So assessment and management. So early diagnosis if and interventions. It's important to do an early diagnosis and intervention. Comprehensive multimodal treatment, example speech, by example speech and behavioral therapy, education and service. Adjustive pharmacotherapy for psychiatric comorbidities. Okay, so yeah, they have to give pharmacotherapy for if you have any other comorbidities. So at the age of 2 children, typically say many words, usually more than 20, and in a second word phrase, like they can combine 2 word phrase. These patients who only recently started saying a couple words has language delay, because remember these kids has 2 years old. It's a girl 2 years old. So though language delay is often an insulated finding, these patients also has behavioral failures concerning with autism spectrum disorder. Okay, so she have all the behaviors that make you think that she have some kind of autism spectrum disorder, because they have a delayed language delayed, and they have something in a when they interact with the other kids. So autism spectrum disorder is characterized by poor social communication skills. Poor social communication skill. Autism spectrum disorder is characterized by the poor social communication skill. By example, lack of response to name, poor eye contact, and restricted, repetitive behavior interest. By example, fixing interest in one toy, difficult adapting to new situation, and like we saw in this patient. So most 2 years old children do not yet engage in interactive play, but parallel play. By example, playing adjusted to others, so like adjacent to others. Like they play next to and other kids, and they play like a kid is playing with something, and you're trying to grab the same toys or no different toys, sitting next to that kid to play. So most of 2 years old children do not yet engage in interactive play, but parallel play. They can play adjacent to others. So is inspected and not noted in this patient's history. So the language difficulty, by example, speech delay, echolalia, are also common in the autism spectrum disorder. The diagnosis requires standardized, detailed assessment of social and developmental skill, typically performed by a developmental pediatrician in children neurologist or children neurologist. So in which the children behaviors is observable while performing a variety of activities. Okay. In a children with suspected spectrum, early intervention in the form of educational behavioral service, like a speech therapy or amplified behavioral analysis, can significantly improve the outcome and may be initiated while waiting diagnosis evaluation. So, as early is better for this kind of kids. Early is better. Let me see if I can find a couple other subject. One second. So autism. So autism spectrum disorder should be suspected in a child with a poor social communication and restrictive repetitive behavior. So language delay is often also present. Patients with suspected autism spectrum disorder require detailed diagnostic assessment as soon as possible because early intervention can improve outcomes. Okay. One of the answers of these questions was anxiety in young children may manifest at school refusal, clanging or parents, teachers, or client, or separation from parents, none of which is seen here. Some children also have selective mutism, in which a child may only speak in a family setting. This patient's language delay is social impairment in multiple settings and are consistent with anxiety. Are consistent with anxiety. Are inconsistent with anxiety. So I mean, like they trying to say that this is not anxiety. So let's see what these texts have to tell us. So autism spectrum disorder is a developmental disorder characterized by impairment in two major domains: in the social interaction and communication. Social interaction and communication. And in social interaction and communication and repetitive restricted behavior, interests, or activities. More common in men. It's more common in kids. And this question was a little girl, but it's common in men. Severity of the is based on the level of support required for each domain. Okay, let's keep going. So, developmental disorder characterized by impairment on two major domains: social interaction and communication, and repetitive restrictive behavior, interest, or activity. More common in men, severity is based on the level of support required for each domain. So the DSM-5 does not distinguish among the pervasive development disorder. So the history, it's a deficit in social interaction and communication, reduced interest in socialization, reduced empathy, inability to form relationship, impaired language development, inability to understand social cue, poor eye contact. The prognosis is best determined by the language development. Restrictive repetitive pattern of behavior, interest, is or activity. So high fixed or restricted interest, inflexibility to change, hands flapping, increased decreased response to sensitive output. Okay, symptoms most impaired functional academic or social symptoms most present in the early development period, typically less than 3 years. The conditions that produce symptoms suggest an autism spectrum disorder must be excluded. For example, you have to exclude intellectual disability, hearing impairment, selective mutism, or Rett syndrome. The Rett syndrome is similar to autism spectrum disorder. It is an X-linked disorder characterized by the marked physical and physicomotor regression at approximately 6 months of age after normal development. Okay, Rett syndrome. Rett syndrome is similar to autism spectrum disorder, but it is a X-linked disorder characterized by the marked physical and psychomotor regression at approximately 6 months of age after normal development. Predominantly seen in girls, patients have a stereotype handwriting movement. Okay, so remember, you have to rule out before. If you're saying a patient have autism spectrum disorder, you have to rule out intellectual disability. You have to rule out hearing impairment, selective mutism, and Rett syndrome. So autism, in autism spectrum disorder, suspect in a children with an impaired social interaction and communication, restricted interest, insistence on routine, will delay language development. Autism spectrum disorder can occur with or without language impairment, varying degrees of intellectual impairment. Okay. I think that could be all for this autism spectrum disorder. Let's see what step 1 has to say about that. CK. This was let me see if we have something about here. Any other questions about I think that could be good for autism. So let's see. I was trying to find a question for you about autism, another one, so I can show on the screen. So the next questions is, let's see what it say. Okay, next question is 65 years old woman come to the office due to feeling her heart race even while she's in rest. She's in rest. She has had multiple episodes like this over the past 2 weeks, lasting anywhere from a few minutes to a couple of hours, and associated with a light headaches. So she's 65, is a woman. The patient's other medical conditions include obesity, type 2 diabetes, hypertension, gastroesophageal reflux disease. She smokes a pack of cigarettes daily of the 16 to 35. Daily from 8 to 16 to 35. So vital signs normal set for an irregular pulse. The patient is diagnosed with atrial fibrillation and given anticoagulation and rate control medication. In preparation for cardioversion, she undergoes thoracoesophageal echocardiography. In preparation for the echocardiogram, cardiovascular, she undergoes on transesophageal echocardiography, which rule out a mural thrombus. Okay, they do transesophageal echocardiography to rule out there's no mural thrombus. So that evening, the patients developed several chest and interscapular back pain. Several chest pain and interscapular back pain. Temperature is high, 38.9. She got fever. Blood pressure is 100/70 milligram per deciliter. Milligram for mercury. And the pulse is 108. Heart rate is 108. The patient is in distress and restless. Heart and lung sound are normal. Echocardiogram shows sinus heart and lungs are normal. Echocardiogram shows sinus tachycardia without ST segment change. Okay, she's not having a heart attack. So checks X-ray reveal a white mediastinum, like big mediastinum, like a big white mediastinum. Stool testing for a cold blood is negative. Which of the following is the best next step in diagnosis of this patient condition? Which of the following is the best next step to diagnose this patient's condition? So what happened to this patient? So after the echocardiography, she started feeling a lot of chest pain. So it looked like her esophagus broke. So which of the following is the best next step to diagnose this patient's condition? So the options are cardiac catheterism. She's not having a heart attack. No. CT angiogram of the chest. Some could be good. CT angiogram of the chest. Angiogram. Repeat transesophageal echocardiography. Upper gastrointestinal endoscopy. They say she's not bleeding. So water soluble contrast esophagography. Water soluble contrast esophagography. That sounds good. So the answer here is, you can pause the video, think, and so the answer is water soluble contrast esophagography. So water soluble contrast esophagography. So what happened? This patient have esophageal perforation. The etiology, instrumentation, example, endoscopy, trauma. Yes. So esophageal perforation. That's what happened to this patient. Etiology, instrumentation, endoscopy, trauma. Etiology, F4 rupture, Borheit syndrome. When you have a lot of F4 and pushing and coughing a lot, you can break your esophagus. Esophagitis, infection, spills, acoustic. Caustic. When you drink caustic, if you drink a lot of bleach or detergent or things like that, caustic, that can produce esophagitis on you and esophageal perforation. So etiology, instrumentation, F4 rupture, esophagitis, esophagitis. Clinical presentation, chest, back, or epigastric pain, systemic sign, and fever. The whole content is spreading. Your fluids are spreading on your chest. This give you that can give you infection in your chest and mediastinitis. So clinical presentation, chest, back pain, or epigastric pain, systemic sign, crepitus, Hamson sign. That Hamson sign is scratching sound or auscultation. Pleural effusion with atypical green fluids. Pleural effusion with atypical or green fluid. So diagnosis is a chest X-ray or CT scan. Widened mediastinum, pneumomediastinum. There's like air in the mediastinum. This is going to be widened mediastinum, pneumothorax, pleural effusion. So the CT scan. In the CT scan, so the diagnosis is first chest X-ray or CT scan. So they are like the same. Which one you pick first? They are kind of the same. Chest X-ray or CT scan. They are on the cell level. They're on the same level. CT scan can demonstrate esophageal wall thickening, mediastinum fluid collection, and esophagography with the water-soluble contrast leak from perforation. I think that's what they said is should be the best next step to diagnose the patient's condition. It is esophagography with water-soluble contrast, so they can see the leak from the perforation. So the management is NPO, nada por boca, nothing per mouth, IV antibiotics and proton pumps inhibitors, emergency surgery consultation. The thoracic surgeon have to open that chest and reconstruct that esophagus. So these patients who underwent esophageal instrumentation, example transesophageal echocardiography, has no severe chest pain, has severe chest pain, fever, and widened mediastinum on chest X-ray, concerning for esophageal perforation. Esophageal perforation. So esophageal perforation is most often due to instrumentation, endoscopy, particularly when performed with the additional interventions. Oh, yeah. By example, biopsia, cauterization, strict dilatation, or common cause is a common cause. Patients may develop several chest pain or back pain due to the esophagus posterior anatomical location and systemic expanding, by example, fever with hour of the pressure. Okay, so the patients present with severe chest pain and systemic expanding like fever. A minority have crepitus, subcutaneous emphysema, or crushing heart of auscultation. That's called Hammond sign. Chest X-ray may be reveal a finding assistant with the air fluid leakage into the mediastinum. By example, pneumomediastinum, unweighted mediastinum, or thorax, pneumothorax fluoride fusion. Visualization of contrast leaking from the esophagus into the surrounding tissues confirmed the diagnosis by either esophagography or CT scan using water-soluble contrast. Okay, so visualization of a contrast leaking from the esophagus into the surrounding tissues confirmed the diagnosis by either esophago or CT scan using water-soluble. They do esophagography. I don't know how to pronounce that. Esophagography or esophagography, or CT scan using water soluble contrast. The barium contrast is more sensitive but can incite to a granulomatous inflammation response. So they don't recommend to drink that barium contrast when they do that because can produce granulomatous inflammation response because that barium is going to be leaking on your chest. That can going to be inflammation process. So it is used when water soluble contrast esophagography is inconclusive. So esophageal perforation is like threatening conditions. Yeah, this is you can die from that. So I remember a patient that a person who eat French fries, and those French fries sometimes they're so crusty, so it's so strong, and the French fry perforate his esophagus. You get perforate. So another way that you can have like a perforation, it is this one. So the chemical peritonitis, with peritonitis, you get symptoms like rebound, tenderness, and guardian. This is when you have peritonitis, chemical peritonitis, due to perforate peptic ulcer. This is another different kind of perforation. It's a peptic perforation. It's not esophageal perforation. It's kind of a little bit out of the subject, but let me read it. So chemical peritonitis, with peritonitis, you get symptoms like rebound and tenderness and guardian due to perforated peptic ulcer. To be suspected in patients presenting with the sudden onset of severe epigastric pain that spread over the entire abdomen. Upright chest with or abdominal radiography typically reveal free air under the diaphragm, especially the right side of the MA diaphragm, because the right side is supposed to be the liver there, so there's no air. But the left side you can get confused with the stomach, so especially free air under the diaphragms, the left side. I'm sorry, the right side, the side where the liver is, the right side. So that's called pneumoperitoneum. So know that free air under the diaphragm look like an X-ray. Look like on an X-ray. So esophageal perforation, esophageal perforation. Trying to find some other place that I can read from. This is the CK. So esophageal webs are associated with iron deficiency anemia and glossitis. Let's remember Pullman-Benson syndrome. Esophageal webs are associated with iron deficiency anemia and glossitis. Pullman-Benson syndrome. So the history of the esophageal radiation or strictures are those patients may be at high risk of esophageal perforation or Boerhaave syndrome. May be followed by a manometry of some case. So I'm trying to find esophageal perforation. No. It's full bodies. So now that we're here in esophagus, let's read couple things for esophagus. So Crest syndrome is calcinosis, renal phenomenon, esophageal motility, scleractilia, telangiectasia. That's a Crest syndrome. Crest syndrome. So okay. This X-ray reveal pneumomediastinum. White. Okay, pneumomediastinum. Like you can see, there's like a line, and there's air in between the heart and the lungs. So white arrows here. Subcutaneous emphysema. So you can see this here. This is subcutaneous emphysema. You can see that line here. This line. You see that line here? This is in the pectoral muscle. This air, and here emphysema. That's the black arrow here. Oh, this is a case of esophageal rupture after a fall from height. Yeah, you can rupture your esophagus even getting a French fry. That's what the history I told you before. A person eating some French fries, and they get their esophageal rupture because the French fries was so strong. So perforation, if you don't bite very well, and if you don't bite very well with French fries, they can perforate your esophagus. So be careful with that. So esophageal perforation, or Beer-Have syndrome. So I don't know how to pronounce that. Beer-Have syndrome. So esophageal perforation, perforation of rupture, sudden onset of this diffuse excruciating pain with a light still to minimize pain. Patients will line still to minimize pain. Peritoneal sign of perforation. Esophageal perforation, or Beer-Have syndrome, is associated with a recurrent vomiting. Hepatomesis is associated with, commonly present with retrosternal and epigastric pain. Retrosternal or epigastric pain. So other GI perforations associated with peptic ulcers. Oh, this is okay. Okay. Okay, guys. So another good notes here. It said, so esophageal perforation is more likely than aortic dissection in patients. Esophageal perforation is more likely than aortic dissection in patients with chest pain who have a wide mediastinum in X-ray. So if you have an X-ray, that's what they said is, if you have an X-ray and you see like there's a mediastinum as very big, like a wide mediastinum, you think better in esophageal perforation than an aortic dissection. So esophageal perforation is more likely than aortic dissection in patients with chest pain who have a wide mediastinum X-ray. So with mediastinum air, so aortic dissection cannot cause pneumomediastinum. So when you do an X-ray, when you see the X-ray and you see like a wide mediastinum, there's air in the chest, and there's air, like I would show you here before in this imagine here. When you see air, most of you guys are driving, you cannot see, but anyway, there's when there's air in between the lungs and the pericardium. That's what I'm trying to tell you. That so the aortic dissection doesn't do that. Doesn't release air in the mediastinum. So with mediastinal air, aortic dissection cannot cause pneumomediastinum. So the diagnostic study of choice for esophageal perforation is water-soluble gastrografin contrast esophagography. Water-soluble gastrografin contrast esophagography. Okay, esophagography, or CT CT scan esophagography. Okay. CT scan, esophagography. Esophageal perforation. I'm sure you guys gonna have a question. So another esophageal perforation can occur due to iatrogenic causes. For example, patient's condition worsened after endoscopy. Okay, you're gonna patient have endoscopy and 2 or 3 hours later get fever, chest pain, and things like that. You have to rule out there's no esophageal perforation. Chest radiography show pleural effusion, pneumomediastinum, and pneumothorax. Water soluble contrast esophagraphy to confirm the diagnosis. It is preferable because the variant doesn't irritate, but it is preferred to variant since it doesn't irritate the pleura and if it is leaks present. So I want you to get that. They usually get water soluble contrast esophagraphy. They use water soluble because they don't want variant to be leaking inside your chest. So we read before that the variant can produce an inflammatory process. Okay. So I think it's good for esophageal perforation. Let's read some other. Let's read another question. So let's read one last question. Thank you guys for being checking on this stream on hit the like button please and subscribe, guys. Thank you very much. Let's see another question. Let's see. So esophageal perforation is done. So esophageal perforation is a life-threatening complication of esophageal instrumentation. Clinical presentation may include several chest, back pain, fever, and wide or big medicine and check X-ray. So water soluble contrast esophagography can be the confirmed diagnostic. They don't want varium. Remember, no varium. Next question. Let's see what we have to learn from this one. Let's see what I have to learn from this question. For the next question. So this is which of the following is the most appropriate next step and the physician should take? Which of the following is the most appropriate next step that physician should take? So 25 years old woman come to the emergency department with a mother due to abdominal pain and fever since yesterday. The patient is epigastric and worse with the meals. Medical history includes male intellectual disability, 2 previous episodes of biliary colics. Intellectual disability and 2 previous episodes of biliary colics. The patient lives with her parents and can independently perform basic activities of daily living. She needs assistance in managing finances and relies on public transportation to commute to and from work or a coffee shop. Temperature is 38, I got fever, blood pressure is 110/75, pulse 120. On examination, the patients appear ill, and is in pain. Palpitation of abdomen reveal positive morphine sign and guardian. Okay, appendicitis. It could be appendicitis. Could be. After initial studies are obtained, the patient is diagnosed with acute cholecystitis. The diagnosis is acute cholecystitis, and cholecystectomy is recommended to prevent progressions, life-threatening conditions. So, all of this, the CK's questions are really long. They tell you all of this just to tell you that patient have intellectual disability. he cannot confirm, he cannot do like his own activities by himself. He need help. He need people who decide for him, for her. She's 25 years old female. So the patient have morphine sign, and they'll tell you that they have cholecystitis, and cholecystectomy is recommended. So the patient say, I don't want surgery. So I just want to take some pills and take last time to go home. Take some pills like the last time I'm go home. Okay, the patient's, but she's not good like to pick. She can understand that what is the life threatening situation that she's having. So I think it's someone in the family have to decide for her. So okay, I just want to take some pills. Take last like the last time and go home. Which will find is the most appropriate next step, and the physician should take. So honor patients declining surgery and have her sign from acknowledge the risk. I don't think so. That could be okay if the patient have will be able to take their own decision, because you know the risk. They tell you what is the risk, and you can sign to go home. But that is not appropriate because these patients cannot, take their own decisions. So involve the patient's mother and explain the need to surgery to the patients in single language. That sounds good, and actually that's the answer. The other options are obtain an ethic consult, given the complex nature of the case, and usually see case at step 1 or 2. Never is almost never is a good answer. Obtain an ethic consult. Never go to take a different consult to somebody or doctors. When they say consult different doctors, it's almost never the right answer. Okay, obtain an ethic consult. No, obtain a consult for surgery from the mother because the patients lack decision-making capacity. Obtain consent from surgery from the mother. Okay, that sounds good. I mean, you can get a consent from the mother because these patients doesn't have a lack decision-making capacity. That could be sound good too, but this is not the correct answer. Perform the surgery with its consent because it is potentially life-threatening situation. Perform the surgery without consent. This is I don't know, that's some cases you had to do because an emergency you had to do, but this is not the correct answer. So the correct answer is involve the patient's mother and explain the need for surgery to the patients in single language. So these patients have acute cholecystitis and cholecystectomy is indicated. However, she is declining surgery and her mind intellectual disability may have prevented her from fully understand the gravity of her condition and need the urgent surgery. So these patients have acute cholecystitis and cholecystectomy is indicated. However, she is declining the surgery and her mind intellectual disability may have prevented her from fully understand the gravity of her condition and need for surgery, urgent surgery. So she doesn't understand that she need an urgent surgery. So rather than manipulate decision rather than prematurely decision that patients with a mental intellectual disability lack capacity to make decisions based on an initial explanation intent. At 10, the physician should undertake additional measures to facilitate patients' understanding the clinical condition, allowing them to make their own decision if it is possible. Helpful can be made including the following: recruiting assistance from family member. Example, explain the mother, and the mother can explain her. Explain information in simple language. Using visual aids or choosing a comfortable setting with minimal distractions. So this is all helpful to explain this patient with an intellectual disability. So recruiting assistance from family member, by example the mother, to obtain the information in familiar terms. Explain information in simple language. For example, gallbladder is sick and need to be taken out. Using visual aids, for example, illustrating the gallbladder, illustrating in a chart, saying, "Oh, we're gonna do the incision here. We're gonna put you to sleep, and we have to take this out. You won't feel anything, any pain." So choosing a comfortable setting with a minimal distraction in a quiet room, for example. So if following further discussion, the patient demonstrates decision-making capacity and refuse surgery, that refusal should be honored regardless of underlying intellectual disability. However, if the patient does not demonstrate decision-making capacity despite those measures, the physician may then as surrogate decision maker to make decision on the patient's behalf. Okay, so if you do all this recommendation to try to explain the patient what's going on and you need the surgery and she is still refuse, then you have to take like the family for decide for them. If it is following if following further discussion, the patient demonstrate decision-making capacity and refuse surgery, that refusal should be honored regardless any underlying intellectual disability. However, if the patient does not demonstrate decision-making capacity despite those measures, the physician may then ask surrogate decision maker to make decision on the patient's behalf. Okay. Assessment of decision-making capacity. So how you know the patient, how you know if the patient can make decision-making by themselves. So assessment of decision-making capacity. So the criteria and the patient task. Let's see. The criteria are communicate a choice. Communicate a choice. Patients able to clearly indicate preferred treatment option. If the patient can tell you clearly indication preferred treatment option, if the patient can talk and say, "No, I don't want surgery," okay? This is assessment decision making capacity. Communicates a choice. Okay, the patient communicates a choice, yes or no. Understand information provided. So if the patient can understand what you're explaining, patient understand condition and treatment options. If the patient appreciates consequence, so the patients know what could happen if you don't get the surgery, for example. Appreciates consequence. Patients knowledge having condition and likely consequences a treatment option, including no treatment. And the last one, rationale given for decision. Rationale given for decision. So the patient able to weigh risk and benefit and other reasons for decision. So if you have this assessment to the patient and he have all of this, he can communicate, he can understand, he can appreciate what could happen and resonate. And then he or she can make a decision based on initial explanatory attempt. So again, obtaining informed consent from patients with mild intellectual disability may require gaining assistance from family members, explaining information in simple language using a visual aids and in a quiet, good environment. So it is best to attempt those measures to facilitate patients' understanding before decision that the patients lack decision-making capacity. Okay. Decision-making capacity. Those questions are sometimes confused, like you don't know what is exactly what to pick. Ethical, legal, professional questions are, you know. Let's read a little bit about consent. Consent and decision making. Sorry guys for this. This is live, you know. So let's see what they had to tell us here. So, true or false? Once patients sign a statement giving consent, they must continue. They must continue treatment. I think it's not. You can refuse any moment. So, false. Patients may change their mind at any time. Exceptions for this requirement of enforced consent include emergency situation and patients without decision-making capacity. Yeah. Decision-making capacity. So decision-making capacity. Let's read a little bit about that. Decision-making capacity. Is the decision-making capacity, competence and decision-making capacity. Competence, decision-making capacity. Competence. A person's global and legal capacity to make decisions and be held accountable in a court of law. Competence is assessed by the court and is distinct from the term decision-making capacity. Incompetent patient, as assessed by the court, or temporarily incapacitated patients may still be able to provide assistance to treat or refuse treatment. However, the need to treat supersede the refusal in an incapacitated patient and emergency situations. Okay, like we said before, if they have an emergency situation, even the patient said no, you have to keep going. Example, in an extremely hypertensive patient with altered mental status who refused treatment may receive antihypertensive therapy, as this condition is a medical emergency and he has altered mental status, so he could be incompetent. So decision-making capacity, the ability of the patient to understand relevant information, appropriate the severity of the medical situation and its concern and its consequence. Decision-making capacity, the ability of the patient to understand relevant information, appreciate the severity of the medical situation and its consequence, communicate and of choice, and deliver rationally about his or her value in a relation of the decision making made. They can be associated by the physician. They can be assessed by the physician, so that the physician have to assess if you have decision making capacity. Decision making capacity is best understood as varying with the complexity of the decision involved. For example, the level of capacity need for a decision about liver transplantation is different from a need to choose between two types of pain medication for fracture-related pain. Yeah, this is something simple. Transplantation is really something big. So, decision-making capacity is best understood as a variant of the complexity of decision involved. Yeah. In general, patients who have decision-making capacity have the right to refuse or discontinue treatment. For example, Jehovah's Witness can I could probably say it. Jews or Jehovah's Witness, can refuse blood product. When a Jehovah, oh my God, I'm sorry. When a Jehovah, I'd say it in Spanish, Jehovah. When Jehovah's Witness lacks decision making capacity, by example, mental status or unconscious, the physician is allowed to provide a blood transfusion in an emergency situation. Okay. A patient's decision to refuse treatment can be overruled if the choice engage the health and welfare of others. Okay. So the patients cannot refuse treatment. For example, if you have TV and it's an active TV and you're spreading TV around your school or your workplace, and the doctor asks you to get treatment, you cannot refuse that treatment. You have to take that treatment. For example, patient's decision to refuse treatment can be overruled if the choice endangers to the health or welfare of others. For example, a patient with the active TB must undergo antibiotics treatment because no treatment will pose a public health threat. Okay, the same. Okay. Uh, okay, decision making capacity. I think we have to keep going with others questions. I think that's gonna be all for now. Thank you guys. You can hit the like button for me and subscribe. Thank you to those people who's watching right now. Let's do one more question. So here we go. Let's see which of the following is the most explanation. Which of the following is the most likely explanation for these patient symptoms? So 65 years old man come to the emergency department due to short breath. Symptoms started a week ago. Dry cough, exceptional dyspnea. Medical history is include hypertension and recent stealing double vessel coronary. Okay, medical history include hypertension and recently stent. They put a stent for double vessel coronary artery disease. They put a stent on him. He has hospitalized 6 months ago for pneumonia. He has 35 pack of smoking history, 35 pack a year smoking history. Temperature is 37.2. Blood pressure is 160/90. And pulse 90. The examination of the patient is mild respiratory distress. Have a mild respiratory distress, but he can't speak in full sentence. Chest auscultation revealed decreased breath sound on the lung base. Bilateral crackles and occasional twists. The arterial blood vessels are pH. The arterial blood gases are AVG are pH 7.46, PO2 73, PCO2 is 31. Which of the following is the most likely explanation for these patient symptoms? COPD exacerbation could be panic attack, result adult respiratory distress syndrome, pneumothorax, congestive heart failure. I don't know. Could be a COPD exacerbation. He smoke. He got a history of this. Then could be CHF too. So let's see what's the answer. So the answer was congestive heart failure. Congestive heart failure exacerbation. There's no COPD exacerbation. The answer is congestive heart failure exacerbation. So these patients most likely have exacerbation congestive heart failure. Okay, let's. So this patient most likely has an exacerbate of congestive heart failure. His history of coronary artery disease with risk factor of uncontrolled hypertension and smoking put him in a risk for heart failure due to the left ventricular dysfunction. On physical examination, patients with worsening CHF or congestive heart failure will commonly have bilateral crackers. Okay, basilar crackers. Okay, the crest breaths on at the base could be due to pleural effusion from CHF. Reasoning can occasionally be present in heart failure, but you would say this is cardiac asthma. So, though these patients with an extensive smoking history may have a concomitant chronic obstructive pulmonary disease (COPD), CHF exacerbation is most likely than COPD exacerbations, given his crackles and his history of his arterial blood gases. Okay, because his arterial blood gases and his crackles is this most concern is most likely to be congestive heart failure. So these patients with an excessive smoking history may have concomitant chronic obstructive pulmonary disease or COPD, CHF or chronic heart failure exacerbations is most likely than a COPD exacerbations, given his crackles and his arterial blood gases, AVGs, finding of hypoxia as well as hypocapnia and respiratory alkalosis. By contrast, the COPD exacerbation is less likely to cause bilateral crackers and more likely to cause significant rather than occasional wheezing and respiratory acidosis. So acute or chronic due to the CO2 retention. Okay, so the AVG helps you to decide if it is congestive heart failure or COPD. Because remember in COPD you have retention of PCO2. So that's what they say here. So COPD exacerbation is less likely to cause bilateral crackles and more likely to cause significant wheezing and respiratory acidosis. So the respiratory acidosis is acute or chronic due to the CO2 retention. So they have CO2 retention. So the more specific testing for CHF would include assessment by for the V-type natriuretic peptide BNP and the pulmonary capillary wedge pressure. So the most specific testing for CHF would include assessment for the V type natriuretic peptide. This is a VNP, V natriuretic peptide, and the pulmonary capillary wedge pressure. Okay, thank you guys. I think this is all. Let me do the educational objective. It's congestive heart failure exacerbation can cause tachypnea as left ventricular dysfunction allow fluid to pool in the lungs. So congestive heart failure exacerbation can cause dyspnea as left ventricular dysfunction allow fluids to pool in the lungs, causing a pleural effusion and hypoxemia due to reduced ventilation. Tachypnea caused hypocapnia and respiratory alkalosis. Tachypnea causes hypocapnia. Tachypnea causes hypocapnia and respiratory alkalosis. Examinations typically show signs of fluids overload like S3 and S4, gallops and cardiomegaly, and V-vascular crackles in the lungs. So congestive heart failure is more more likely in this case. Okay. Thank you very much, guys. See you next time.